we'll talk about alcohol use disorder, sadly a very common presentation in our emergency department, sadly a condition that many of our patients don't know they have. This can present with acute intoxication, slurred speech, incoordination, impaired judgment, as we often see, and increased risk of trauma. Alcohol use is recurrently a risk factor for traumatic injury. Chronic use of alcohol can be complicated from liver disease and cirrhosis and can also cause a variety of nutritional deficiencies. We often see these patients presenting with early withdrawal. They might be a little restless, tachycardic, hypertensive, maybe a little tremor. Late withdrawal or delirium tremens, the delirious state of alcohol withdrawal, typically takes about 3 to 5 days to develop. These are the patients who have delirium, hallucinations, autonomic instability and swings in their blood pressure that can precede death. And then we frequently see seizures. These can be early, sometimes called rum fits during early withdrawal. They have short or no post-ictal period, or they can be seen later and have more prolonged seizure activity associated with a post-ictal period. Management of alcohol withdrawal is frequent administration of benzodiazepines. We use diazepam at my shop. We're also using phenobarbital a lot more often. It's a little more potent as opposed to benzodiazepines, which increase the frequency of chloride channel opening. Phenobarbital actually holds the door open. You can also use propofol, and there's a variety of adjunctive medications that can be used for alcohol withdrawal. This includes gabapentin, Dex, and haloperidol, even ketamine. It's really helpful to use a symptom-triggered withdrawal scale when giving withdrawal medications, such as the CEWA scale or the MIND scale. Using these scales has been shown to reduce the overall amount of benzodiazepine administered to the patients with good outcomes.